Hello, everyone. I am Dr. Sajjad Akbar. I am from Margherita. I worked in Coal India Limited for 20 years and now I am practicing in Margherita. So today I'm before you to talk about a small aspect of diabetes mellitus. Diabetes has become a household name nowadays. I'm sure everyone will agree. Diabetes is the disease which consumes most of the time in a physician's clinical practice. Just like the disease, its treatment is also complicated. There are various modalities of its treatment. Physicians make different calculations in the treatment of diabetes. Today, I shall give a brief account of a small variation that I feel will be useful in the treatment of type 2 diabetes, which is the commonest type encountered in our practice. I shall take up a case study to highlight this mode of treatment. Let me not take the name of the patient. Mr. AB, a 45-year-old with newly diagnosed type 2 diabetes, visited the clinic 6 months back. He had multiple risk factors like obesity, hypertension, hyperlipidemia, etc. He was initiated with metformin with advice for lifestyle and diet modifications. Along with metformin, he was receiving lisinopril, metoprolol, atorvastatin, and aspirin. When he visited the clinic after 6 months for routine checkup, his laboratory parameters were hemoglobin A1c 8.5%, GFR 80 milliliter per minute, LDL 80 milligram percent, HDL 38 milligram percent, triglyceride was high to 200 milligram percent, BMI 31 kg per square meter. Blood pressure was normal 120/70 and heart rate was also normal 78 beat per minute. In other words, he still had levels that were not satisfactory except for blood pressure and heart rate. Evidence indicates that early intervention and achievement of glycemic control reduces the long-term risk of microvascular and macrovascular complications in type 2 diabetes. UKPDS demonstrated a legacy effect of early intensive therapy because the difference in the cardiovascular event rate 10 years post-trial was apparent, even though there was no difference in hemoglobin A1c levels between intensive and conventional therapy. When metformin is not suitable, empagliflozin or linagliptin is considered as an alternative first-line treatment. Even initial combination therapy may be considered to achieve target more quickly, particularly in patients with high baseline hemoglobin A1c level. Early combination therapy in type 2 diabetes makes sense for several reasons. First, a meta-analysis demonstrated that early use of combination therapy significantly increases the likelihood of achieving the glycemic target of hemoglobin A1c less than 7% compared with metformin monotherapy. For patients with hemoglobin A1c more than 1.5% above goal at diagnosis, ADA and EASD guidelines recommend first-line treatment with a dual combination and SGLT2 inhibitor as the first post-metformin treatment in patients with established cardiovascular diseases, chronic heart failure, or chronic kidney disease. EMPA and LINA combination with complementary mechanism and pleiotropic benefit may be a suitable option across a range of patients, including those with established cardiovascular disease or high risk of it, or established heart failure or chronic kidney disease, due to the tolerability of the combination, in addition to the potential benefits of empagliflozin on cardiovascular and renal outcome. Moreover, there is no increased risk of heart failure with either agent. According to study, early achievement of hemoglobin A1c goal of less than 7% could be achieved at 12 weeks compared to a much longer period with monotherapy. Hemoglobin A1c decrements by EMPA or LINA, 25 milligram EMPA or 5 milligram LINA, has demonstrated 1.81% reduction from baseline of more than 8.5% 24 weeks in metformin-treated groups. The benefits on glycemic control were maintained at week 52 in metformin-treated group and a higher percentage of patients achieving hemoglobin A1c of less than 7% were reported for combinations. Thus, combination offers a suitable component in this strategy to achieve target hemoglobin A1c without increased risk of hypoglycemia, weight gain, or overall lipid profile. A reduction in the incidence of genital infections associated with SGLT2 inhibitor has been reported when a DPP4 inhibitor is added. To summarize, EMPA and LINA combination provides robust hemoglobin A1c reduction and a 2 to 4 times higher odds of patients reaching the goal of hemoglobin A1c compared to monotherapy, and that too with low hypoglycemic risk. That's all for today. Thank you for listening.